now to be working at Blueberry Therapy with you, Kristen, and your great team of fabulous healthcare professionals that you have working with you. My experience then comes with my work in pediatrics with babies all the way up to 19 years of age, and various kids with various diagnoses or motor issues, you name it. I've seen lots of kids with different limitations and issues. So tonight we're going to just focus on children and walking, running issues, and to explore sort of as a parent, when should we be concerned and when should we search for help by a physiotherapist. Okay, I'm going to go through just the table of contents. At any point in time, I don't mind the interruptions and asking questions, because I think that with this topic, there are certain points in time where I'm discussing something or sharing something and you have a question, that it's good timing. So please just let me know, and be happy to stop and have a discussion about it or answer the question, or you can write it down and leave it till the end of the presentation. So we're going to talk about what is walking and running, and what, I just want to get the little boxes out of the way. What you do, can I just ask this question, Kristen? On my screen,
Yep.
the gallery view is blocking my slides. It's not blocking yours, is it?
No, and it just all depends on how each person views it. When I'm presenting, I usually hit the second kind of medium-sized single bar, and then I can see myself and just the slides.
Second one in the middle. Okay, so I just see you, but that's okay. I don't need to see myself talking. Okay, so we're going to talk about walking and running, and what do you need in order to do that skill, some of the causes of abnormal gait, and what those look like, and when you have to do something about it, and of course how us as physiotherapists can help you. And then at the end we'll address questions and have a great discussion. So typical gait is the same thing as walking. I like to put this slide up because I want to show you sort of what, as a physiotherapist, I look at when I'm looking at your child walk. So gait is another word for walking. And you can see there's various phases of the cycle, but generally I want to point out that there is a stance phase, which is a big chunk of the cycle, and a swing phase. The stance phase really is just the time that your child, anybody who's walking, has weight on one limb. And as soon as you hit that heel on the ground and you start to put weight on that leg, that's the beginning of stance phase. And when you take weight off that leg, then that's the end of stance phase and the beginning of swing phase. And swing phase is, like it means, is the time frame where your leg is off the ground, swinging underneath you and getting ready for the next beginning of the gait cycle. Okay. Typical gait, development of normal, mature gait involves several factors and years of practice. And I think that that's important to point out, because walking is a very complex task, and it's not something that can sort of happen overnight or over even a few weeks. So the many young children can have an abnormal gait cycle at any point in time as they're learning to walk. So when you think about it, they might master a certain part of the gait cycle, and then they go through growth, and they're always growing. And when their bodies grow, it changes how they carry weight on their legs, and constant readjusting of things that are changing, and learning to walk. And so I just want to point out how important it is to know that learning to walk and run is a very complex task, and it takes a very long time to learn to do that task and to do it well. So it's very normal to see your little one with a wide base, which means when I look at their feet and where they place their feet, they're not necessarily right underneath their hips, but they're past the position of their hips, and out wide, as it says. They might even turn their feet out. And what they're doing is trying to get more stability, more support. Their stepping is usually very short. So they might just lift with their hips and knees bent and place the foot not much past their foot where it was in the first place. So it's a very short stepping. Often we'll see flat foot, and I'll go into the foot development a little bit later. And we might even see their arms outstretched because they're looking for stability. So all of that is quite typical and quite normal. Okay, every child develops this complex task at their own pace. And at the bottom of my slide, I wanted to point out, so if your child starts walking, let's say around 12 months of age, you can see that they don't even reach a heel strike, the beginning of the gait cycle, until they're about 18 months of age. So when you think about that, that's 6 months of walking to learn how to control that heel position. And the heel toe gait pattern, which means they place their heel at the beginning and they push off with their toes at the end of that stance phase, is not achieved until they're 3 years of age. Running, we don't even see at running until around years of age, because running is the same as walking, but it requires quicker transitions and movements of those muscles. And the adult gait and posture is not seen until around 8 years of age. Are you going to let Angela in? Kristen, are you there?
Sorry, I was talking and I was on mute. Sorry, I just let her in.
Thank you. Hi, Angela. I don't know if you're on quite yet. I just started, so you just missed a little bit. My name is Deana. I'm a physiotherapist at Blueberry, and I'm talking about walking and running in children. So, typical gait development. Again, I wanted to point out that how complex a task this is. I know Deidre went through the milestones at different ages, months, and walking is one of those milestones. But I wanted to point out that it happens, the development of it happens at the brain level, at the spinal cord level, at the legs of, at the legs of course, and the body and core. And so when you think about all the things that have to happen at all those levels, it can take some time. So going back a little bit to the milestones, achieving all the motor milestones and building on those skills leads to a more mature gait. So I put in the few key ones that your child needs to have accomplished before we can even talk about walking. So independent sitting helps that child get to a point where they have control of their trunk. They're not going to fall over. They've got a stability when they're sitting on their bum. And that happens around 9 months of age. And then they progress to a high kneeling position where they then learn to shift their weight from one side of their body to the other, and bearing weight now on their knees versus their bum. And so time is needed for them to figure out what muscles hold them up and how they can actually start to transfer weight from one side to the other. Then they progress to around 11 months of age to cruising. So that's when they pull themselves up to standing and they're walking along the couch, let's say. That repetitive walking from one side to the other allows them to strengthen their legs, so strengthen the muscles in their legs, strengthen their trunk and their pelvis, and it allows them to develop more hip control so that they can keep themselves stable and lift one leg up without falling over. That takes a lot of practice. The righting and equilibrium reactions are constantly being challenged at different phases. And so they, at this point, they would have worked on righting and equilibrium, which is when you put your baby in sitting and they don't fall over anymore, they've fine-tuned the righting equilibrium reactions, okay? So if you were to give them a little push, they put their hand out. That they have learned that and what muscles they need to do that. It's not conscious to them, but their body can react to that. So now at 12 months of age, when they're up on their feet, they now have to fine tune those two reactions now that they're on their feet. That takes practice. I made 2 columns because I was trying to figure out how to give you a list of things that might interplay with your child's gait, that might influence this normal gait pattern that we're looking for. So what I did is put on the left side, what is your baby born with potentially that might influence gait development? And on the right-hand side, as the baby is growing and developing, what might be influencing their gait. So on the left, some babies are born with low and or high tone. Usually the low tone is in the trunk or in the core, and usually we find the higher tone is in the legs. Tone has to do with the messages that your muscles get from your brain. So we want sort of normal tone that helps our bodies to stay upright and be in control. If you think about a low tone in the trunk, those are some individuals, and you can see adults with low trunk tone that have a hard time sitting up straight all the time. They fatigue quicker and they have more of a slouched posture. It might be that they have a little bit lower tone, helping them to engage those muscles to stay upright. And you might have a baby who has low trunk tone, and that's why they didn't achieve independent sitting by 6, 7 months of age. It might have taken them a little bit longer, okay? There might be a genetic influence, or structural, what they're born with. They inherit what mom and dad gave them. So some kids come to see me with difficulties with walking or not having learned to walk yet because of hypermobility. Hypermobility has to do specifically with the joints. So it's not about the muscles or the bones. It has to do with the joints, ankle, knee, hip, might have extra movement. And when there's extra movement, that individual feels unstable. And that can influence how they walk. Some kids are born with what we call DCD, developmental coordination disorder. These are kids that we used to label clumsy kids in the classroom. They would bump into desks and chairs all the time, or have a hard time learning new sports. They also have challenges with writing. They have messy handwriting. They have a hard time with holding utensils when they're eating. So motor planning is a really important part of gait. And if your child has a hard time with motor planning, then you can maybe see that in how they're walking. Some kids are born with sensory issues. And I don't want to go into a lot of detail about that, but there's some kids that either have sensory seeking, so they're seeking more input through their feet, or they're trying to avoid it. And that can change how they walk. If we look on the right-hand side, as your baby goes through the milestones, there might be weakness in certain muscles that then causes them to move in what's called asymmetry. So the right side of the body moves different from the left side of the body. And one example I can give is I see a child up just learning to walk, but they turn the right foot out and maybe take a step wider than the left one. So that's what I would call an asymmetry. Is it because of weakness on the right side of the hip? And so I would look at that to see. Some kids don't learn to crawl, but they butt scooch. So they're sitting on their bum. They have one leg up in a bent knee position, and they try and pull themselves across the floor in a seated position. If the child uses that for mobility, it can cause asymmetry because they're using the right side of their body different than the left side of the body. Okay, so that goes into habitual patterns. And bone development really talks about the phases of bones. So our bones go through different phases of growth. And so I'm going to go into a little bit later in some slides about our bones will go into bow-legged position, and then knee valgus position, so inward, and then they finally straighten. So that bone development can influence how your child walks. And this one I really want to point out, because I think that we always forget that our little people, our little children have personalities, and that can influence how they move. And so you have maybe one that's a high risk taker, so they just, pull themselves to stand and just go. Or there's ones that are more cautious. Maybe they fell once and now they're just like, I don't want to be up on my feet anymore. And they're very, very cautious with how they walk. That can influence how they walk. And we have to keep that in mind. And then I've got other little ones that I've seen that just move so fast, they don't even have time for their bodies to catch up. So those are the ones that are maybe falling all the time. And so I wanted to point out that we have to look at their personalities too, when we're trying to tease out their gait. So more specifically, let's go into a little bit of some of the things that you might see that brought you here tonight to get some answers or to have some great discussion. The most common ones that I see are kids that walk by in-toeing. So that obviously is their feet going inward, or out-toeing, which I don't see very much of, but sometimes I will see a child out-toe with one foot, as opposed to the in-toeing is usually both. Bow-legged, as I mentioned, is they're walking and you can see a bigger distance between the knees. And then knock-kneed is the opposite, so their knees are coming inward and actually can be touching. I've seen lots of toe walking. That's another very common one. And there's lots of different reasons for toe walking, and I'll go into that a little bit later. And then probably the last bigger one is, as I mentioned, is the asymmetry. You might see your child walking, doing something different on the right side of their body than their left. Pace good for everybody. I'm just wondering if I'm going too fast. It's hard because I don't get to read anybody's faces. And if anybody has any questions at this point, I'd be happy to answer those.
I think the pace is great, Deana. So far, we don't have any messages in the chat, but do people on the call want to ask a verbal question? I think we're probably okay, Deana. Keep going and then we'll have lots by the end, okay?
Okay, super, thank you. Okay, so I'm not going to go into a lot of detail. I'd be happy to address questions because I want to get a feeling from you what brought you tonight. And I want to spend more time talking maybe specifics, but here's one of the common ones that I think is important to point out, because the little ones you will generally see in-toeing. And there's a couple of different reasons for in-toeing. One of the more prevalent ones is tibial torsion or femoral version. That really is the femur, or the long bone of our thigh is the femur. And sometimes the bones can actually grow and start to rotate slightly through their shaft. And that then repositions the leg. So if it's femoral anteversion, it will turn the feet inward. If it's tibial torsion and it's rotating inward, it will pull those feet inward. So as a physio or orthopedic surgeon, we'll look at those long bones and how they're developing to see if they are contributing to that in-toeing that you see in your little one. Same thing with the out-toeing, but again, in-toeing is a bit more common than the out-toeing. This can be quite normal in bone development, in the phases of bone development, and it usually can correct itself with time and no intervention is needed. And usually that's around over 8 years of age. I wanted to point out though that what I have found as a physio is the common ones, if it's not the torsion of the bones, muscle imbalances can play a part, and or flat feet. But flat feet, some kids are born with, all kids are born with flat feet, and it takes up to 10 years of age to actually form an arch. And so the flat feet can change the position of your limb or the position of your leg as you put weight on it. this is what I wanted to point out. So in a lot of cases, I'll see a child that has started walking and the parent will say, well, she's in-toeing quite a bit and I don't understand why. And if I checked out the bones and there's no concern with the position or development of the bones, I'll look at the muscles. And when there's a muscle imbalance, so tight muscles that pull the leg inward and weak long muscles on the outside, often that can happen because your child W-sitted when they were younger. So when you had your little one learning to sit, they may not have felt stable. And so they decided to go into a W position. And this made them feel stable. But what happens with prolonged W sitting is it leads to a muscle imbalance at the hips. And then that leads us to physiotherapy, where we can give some very specific exercises to help fix that balance, correct that muscle imbalance. Another common one that parents might see and make you alarmed.
Oh, I think she froze. Let's just give her a second and see if she comes back on. If she doesn't, Deidre, you can take over, okay?
Oh, I froze?
Oh, did I? Yeah, you froze. But it's okay. Deidre volunteered.
What did I miss?
I don't know. You're all good now.
What did you guys miss? Okay, so I'll just start at the top of this slide just in case you missed the beginning. So let's look at bow-legged and knock-kneed. I just want to point out that this normal bone development, so not panic when you see your child and chart ages concerning those positions beyond the years where they should have corrected. Okay. Sure. So just so you know, children of my own. And my daughter, she used to walk to at Civil. If you look at my, she's bow-legged, normal bow-legged, and she's bearing weight on the outside borders of her feet. So I looked at that and I thought, that can't be good for her. So I took her to an orthopedic surgeon and I said, I know this is normal, but babies don't usually walk at 7.5 months of age. Now that she's putting forces on those joints, is this going to make it more bow-legged? Is it going to cause problems with her feet, etc.? The orthopedic surgeon said to me, don't worry about it. And I didn't after that. She corrected herself and she's great. She's 16 now and she runs great. So I just wanted to see my child with bow-legged walking kind of scared.
Deana,
you that you is in what eating, but yeah.
Can you hear me, Deana? If everybody's hearing it the same way that I am, your video is, or not, video is pausing, but the speech is slowing down. There's just your internet must be a wee bit unstable.
Okay, if you just give me 5 seconds, my husband is the IT guy.
Yeah, great.
I'm gonna check and see if he can do anything different for me.
Okay, that's great. Yeah, I'm hearing from participants that we're hearing it like you're under molasses a little bit.
Ian, the internet's slow. They say that I'm cutting out and glitching and
Her husband is an internet guy, like an IT guy, so it's handy to have around, I think.
maybe if I go on my phone, I get better reception on my phone.
While Deana is coming back, I'll tell you a funny story. When I started as a pediatric only physio at the Lansdowne Children's Treatment Center. And when you graduate from physio, you know a little bit about pediatrics, and I loved kids, so I was really invested in learning, but you don't know that much. And for the entire first like 8 months that I worked at the Children's Treatment Center, I'd be assessing kids who had very flat arches. They were anywhere from 1 to, let's say, 3. And I kept sending them to an orthotist to get orthotics because I felt like they needed an arch. And then I went to a phenomenal course. It was called Developmental Biomechanics for Children. It was one of the best courses I ever took as a physio. It was a 7-day course. I met Deana on that course many, many years ago. And during that course, I learned that children don't start developing an arch at all until about age 3. And as Deana explained, the arch then continues to develop until probably about age 8, and then it looks more adult-like. So the orthotist that I kept sending these kids to didn't say anything. He was probably very thankful that I was creating more business for him. But these poor parents, I still think about that as a very young physio. And I hope she's coming back. What else? We are looking at kind of a nice little slide here of all these different leg types, right? Which she's going to go over a little bit more. Deana, oh, perfect.
Hi, can you hear me now?
Yeah, perfect. Whatever you did worked great.
You want to know what I did?
What?
I have 3 teenagers. I kicked them all off their internet.
Yep, that was probably the best possible thing. Okay, go for it. You're great.
So don't be surprised if they all come in here and join us now. Anyway, so back to the bone growth. So if there is, if you do see this and it's beyond the ages where you should be seeing it, some of the other things that can contribute to it, other than the metabolic disorders or genetic disorders, is carrying extra weight. Or if your child had an injury, it can affect the bone growth. And so you want to get that checked out by an orthopedic surgeon. There may be signs of some arthritis. And I don't think that this is common for us because we know so much now about vitamin D, but deficiency in vitamin D can be a concern for bone development, bone growth. And I just put at the bottom there. So if you see the bow-leggedness beyond 2 years of age and it's significant, you should get it looked at. If the knock-kneed is seen beyond 7 years of age, then that should be looked at by either a physio. You can start with us. We're easy to get into versus an orthopedic surgeon, but often it's a good idea to connect with an orthopedic surgeon as well. Toe walking is probably the most common gait problem that I see. It amazes me how many kids are walking on their tippy toes when toe walking is not part of the gait cycle. As you remember, I showed you the gait cycle, a typical gait cycle at the beginning of this talk. There's no point in time where walking on our toes is considered normal. And so I'm pointing that out because when your child goes up on their toes, they're telling you something. And it might just be a lack of stability. They go up initially when they're learning to walk and then they come down. Well, that's okay. But there might be some other things that we need to rule out. And the big ones are the neurological conditions like cerebral palsy. And that's where they have increased tone to those muscles, the calf muscles in the back of the leg, that's driving your child to go up on their toes. So that needs to be ruled out. As I mentioned earlier, I'm getting more and more referrals for hypermobility. So that's excess movement at the joints. If there's too much movement at the ankle joint, that could drive them up on their toes. What's really interesting is children don't know why, and they don't know what's making them feel unstable, but they're very clever at compensating. And so toe walking is a real compensation to tell me that they're doing that for some reason. And hypermobility, it seems to be just becoming more and more aware, and more kids are coming to see physiotherapy for that. But so going up in their toes, it actually stacks their bone, their ankle bone, on top of their bones under the foot bones, and they feel solid. And that's why they stay up there. As I mentioned earlier, some of the kids are seeking or avoiding. So if your child doesn't like to walk on sand or grass, they're going to get up on their tippy toes to get away from it. That's typical for most kids. And they become comfortable with it, and then they start to come down. But if your child stays up there, your child might actually be hypersensitive and have a hard time dampening that sensation that they get, and they might have a hard time dealing with it. So we need to look at, is there a sensory issue? Some of the other things are just delays in general with the motor milestones. If your child is born premature, it can lead to toe walking, or if your child has a huge growth spurt. And of course, a large population of the kids with autism walk on their tippy toes.
Deana,
I heard Chris, yeah.
I'm so sorry to interrupt. There's a question from the audience about shoes and whether shoes, if there's a type of shoe for toddlers that you would recommend.
It's a good question, because I think I get that pretty much all the time. The shoe companies generally design shoes with no arch, so they're flat. And they do that because they don't want to influence the development of the foot, the natural development of the foot. So, but if you have a child that is showing signs and symptoms of having a problem with walking, that's when I would get into a discussion about specific shoes. But I wouldn't say that you needed to go buy anything in particular or anything special if your child is doing normal development, normal walking. So the answer to the question really comes when it's more specific. What is the problem? And then I can get into the details of what shoe might help that foot. In general, for example, I can give you an example because I don't know who asked the question and what the problem is, but let's say I have a child who has hypermobility at the ankle and they are 16 months of age and still not walking. The first thing I would do is try them in a high top shoe. A high top shoe that's made of nice soft leather, but it's firm, and that goes up around the ankle joint to give stability. And the second feature of that shoe would be a stiff sole, so that they have a solid foundation under their foot. And then I would assess to see how they do with walking with that type of shoe. So I'm not quite sure if that answers your question. I'd be happy to, we can maybe talk about it at the end. But it really depends on what I'm seeing and what the child is telling me they need. And then I can talk about different shoes. Okay.
That sounds good. And she's saying that there really are no problems, but was wondering more if there's anything to avoid, and if like things like shoes with thick soles are detrimental to walking, that kind of question.
Yeah, no, I think if your baby is generally developing healthy, normal, they're not toe walking, they're not showing signs of instability, hypermobility, any shoe is fine. But having said that, I have seen some shoes that are, not very supportive or cushiony. And I think that those two features, some type of support and structure, some cushioning, I think are important. But remember, and I heard Kristen talking about the arch, we don't want to influence or have an impact on the foot muscle development. And so you don't want to put something there that's going to be in the way of the child activating those muscles and using all aspects of their foot. So I would always go back to the shoe discussion if I see a problem. If I don't see a problem, I don't really worry so much about the shoes. Yeah, unless the shoes are causing a problem. Okay. Sometimes we see little ones limping all of a sudden. So they were walking fine and now they're limping. So limping is when they're not willing to put weight on their leg, or they're lifting their leg up and kind of swinging it outward to put it down. Often those kind of gait patterns are a result of they injured themselves, and kids move so quickly and they don't pay attention to where they're moving in their environment, and it's not uncommon to get little sprains and aches and pains, tired muscles from walking at the zoo, for example, or getting blisters from walking in. This is where I would say if your child is getting blisters, have a look at the shoe that you chose to buy. But and then of course the worst ones are maybe they have a fracture or a dislocation. Sometimes there's joint swelling from an injury, and so don't exclude those things. I have had kids come to see me as a physio, and it turns out that we discovered that there was a fall and it led to a knee swelling. And with time, those things should resolve. And that's the key, is it should get better with time. With kids, it's really hard to know if they're having pain. They don't know how to verbalize pain. When you ask them, where does it hurt? They don't know how to point to it. You certainly can't get an idea of the level of pain. And so I think your best skills are to watch them, how they move, what they're not doing that they could do before, and seeing over time whether it's improving. And if it's not, get in to see a physiotherapist for sure. Sometimes kids have a leg length discrepancy. If it's a difference of 2 centimeters, that's normal and we don't worry about it. If it's bigger than that, it can change how they walk for sure. When one leg is longer than the other, it's noticeable. And in fact, I have a story to share with a child I saw today. He had been referred to me for something else. And when I assessed his walking and his stance, I determined a leg length discrepancy. So I said to him, when you go see your orthopedic surgeon, get that looked at. And let's have a look at your x-rays to see, because that had an impact on his gait. And so we're going to look at that and explore it a little bit further. Some of the other reasons for limping is arthritis in the joint. So there's pain and swelling in the joints, and it can change how they bear weight on their feet. And cerebral palsy is the increased tone, and that will change how they walk. Often these are kids that have only one side that has increased tone and the other side is normal. So those are the kids that we call hemiplegia. I have seen a few little ones, like little guys, come to me with this C-shaped foot. It happens in utero usually, so you can see this very early on. It's not something that I see later in the toddler years. It's the early months. And it looks like a C shape. Usually this resolves on its own, 90% by 1 year of age. I think the key is development of the foot. So as they're putting weight on their foot, they're activating the muscles. It can help change that shape. The stronger those muscles get, the more exposure that foot gets to weight bearing on the ground. Some kids though, if they're born with a severe C shape, they do need to get put into casts that they keep on for several weeks, and or they'll then shift to special braces, which are basically leather shoes that have a bar, and it keeps that foot in that position to help it to realign itself. As a physio, I have given a few exercises that might help to contribute to the correction of that foot, but it does take time, and I don't expect it to change quickly. It's sort of as they become more weight bearing and they're on their feet more, we start to see more changes in that foot position. I'm just trying to find my arrow. I lost my arrow to change my slide.
Can I ask you a question, Deana? It's Deidre.
Yeah.
Do you have many families with metatarsus adductus ask about wearing shoes on the opposite feet?
Mm-hmm. Yeah. I don't know if that's good or if that's bad.
Yeah.
In a way, it kind of, I mean, from a biomechanical point of view, it makes sense to me. You want to create a wall, right?
Right.
To block that foot from going in. And by putting the shoes in the wrong foot, you've got a wall there that will do that. My only concern is, what about the rest of the shoe? And is it causing pressure in other areas that we shouldn't be putting pressure in? You know what I mean? Like, I would rather the child see an orthopedic surgeon who then can decide that it's clear enough that it needs to be put in custom cast or a custom, the special custom shoes that then can give enough support and cause that change to happen gradually, but not putting extra pressure in the rest of the foot. Does that make sense?
Yes, thank you.
Yeah. So why are we talking about this abnormal gait? What are the concerns other than the child walking funny? I just put together a list of a few things. So if the child is walking with a funny looking gait, my concern is the abnormal forces going in the wrong spots. So our foot is designed to bear weight a certain way, our knees, our hips, and our back. And if they're walking for a long period of time incorrectly, those abnormal forces cause trauma, not necessarily severe, but it can stress, pain, the ankle, the knees, and the back joint. Over long term, it can lead to changes in muscle length. So some muscles might get shorter, some might get longer. And gait only gets better when you walk normal gait, because normal gait helps to strengthen those muscles that you need walking. If you're walking asymmetrically, right side differently than the left, or if you're walking with your feet turned, whatever, up on your tippy toe, you're not strengthening your muscles the way they're supposed to be strengthened for normal gait. So the child is missing out on going to the gym, basically. Gym is add a lift weights and make certain muscles stronger. Well, for them, it's normal walking that strengthens that need to be strengthened the way they're used in gait. And so I always want to get on top of gait as soon as there's a concern, to ensure that we are optimizing that muscle strength development and the muscle length development. And that's how our muscles develop, is through normal movement patterns. Okay. The other big thing is either the child's in or they're falling all the time because of their gait pattern, or they have an increased risk for falls. And this can be really concerning as a parent. Because your child's falling all the time, it doesn't leave them safe in a lot of different environments. And so looking at gait to see if there's anything that we can do as a physio to help a little bit. And it might be, as Kristen mentioned, I think you said you referred everybody to orthotics. Well, I think there's a time and a place for custom orthotics. And kids that are falling a lot, I often look to see, is there an orthotic device that will help them to stop them from falling? Because that's a real concern for parents. And then I also hope that that orthotic will help them to normalize their gait so they can develop the strength and the length of those muscles that we're talking about. Okay. And of course, the other thing too is you might have a child who wants you to pick them up all the time because they fatigue really quickly, or they start to get aches and pains. And they're having a hard time covering a distance that maybe you saw your other child have no problem doing. It's really important to listen to them because they're telling you something about how they're using their body and what's causing some problems for them in their normal function. So I kind of just talked a little bit about how physios can help, but I wanted to just sort of show you generally. A physiotherapy assessment involves really history taking. So I want to know if there's a family member that has flat feet, or a family member that toe walks or has in towing, because often that's handed down. I will want to know how long they've been toe walking, or did they start toe walking later? How long is the in towing? Whatever the problem is, a good history taking is really important. And then I get into the specifics with the child. Do they have full range of motion at the hip, at the knees, at the ankles? Do they have motor control? Can they move that hip and knee themselves? Can they control their foot position? How stable are the joints, hip, knee, and ankle again? I look at their motor skills. I want to get a good history, milestone development. What were they doing when they were 6 months of age? What were they doing when they were 9 months of age? How did they look? How did they move? Gait, of course, I will look at how they walk and tease out each phase of the gait cycle, whether it's stance phase or sway phase, to try and determine where is the error happening and why. I look at tone of all the muscle in the lower extremity, and then I do a very simple sensory profile. Usually it's more around talking to the parents. When they first started to walk, do they like to wear shoes? When they get home, do they take their socks and shoes off? There's some signs that tell us about some sensory issues. And then in terms of what we can offer, there's lots of things we can do. But the key is individual intervention. So as I mentioned, it's hard for me to just sort of give a global or simple answer about shoes. It's really about, I look at a foot and then I decide sort of what that foot needs, if that makes sense. We look at lengthening. So how can we get some stretching to those tight muscles? And it could be day, night, it could be through bracing, it could be through serial casting, or it could just be through you doing some stretches, or you putting your child into certain positions that they can do some stretching. Same thing with muscle strengthening. What can you do to get your child to strengthen the muscles that I think are weak? That's contributing to your abnormal gait. Gait training is really specific, looking at those parameters of gait and working on different aspects of that. And then there's some modalities that we can use. Electrical stimulation is basically a little unit that we can use to put little electrode pads on the muscles. And it's very comfortable for the child. It's not painful, but what it does is it just kind of wakes the muscle up and it helps that muscle to do a contraction. So if I think the muscle needs a little bit of help with that, I use a muscle stim. I love kinesio tape because you can tape joints to give stability. You can use the tape to help activate muscle use, or you can use the tape to dampen down muscle use. So there's lots of different things. And as long as the child's comfortable with tape on their skin, it's a very easy method to use. And of course, the last resort is referral to an orthopedic surgeon for possible surgery. But I just wanted to point that out because often these little kids come to see us first, and then we're the ones that say it's a good idea to hook up with an orthopedic surgeon. Not necessarily to have surgery, I want to point that out, but orthopedic surgeons can also tell you how your baby's developing in terms of bone development and joints, etc. So if we think there is a problem, it's really nice to have that doctor on board, and they might just see your child every 6 months to assess their development. And so it's not about having surgery, it's more about how are they developing with those bone structures, the joints, the muscles around them. I just put this in just to show you a little bit again about custom bracing. We don't do it as physiotherapists, but I work hand in hand with orthotists to decide what type of device might help that little foot. It might be an orthotic, which just goes in the bottom of the foot. It might be something to come higher up to hold the ankle joint and give more stability there. Or it might be something that has to come up the back of the leg and wrap around just below the knee joint to give more support and stability. There might be just a need for nighttime stretching. So there are braces that you can put on just to help stretch the muscles while the child is sleeping. And that's sort of the nighttime stretching orthosis and the knee immobilizer. So there's a few other things out there that we can use that are effective to help with some of the issues with gait. And at this, I want to thank you very much for spending your evening listening to me tonight. Hope you felt, learned some stuff, or it has stirred up some questions. And I'll let Kristen take over to open the floor for questions and discussion. And again, thanks very much for letting me talk tonight.
Deidre, that was great. You covered a lot of information and gave some really good ideas about, you know, what you might see as well as what you might do if there were some issues. I love that you touched on W sitting and the impacts of W sitting with ankles and hips and feet, because we do tend to see that a bunch. And that's something that, you know, as parents of young children, we can kind of watch for and try to give some strategies about to prevent future knee, hip, ankle issues. I'd love to hear from the audience if they do have any questions, or it's a fairly small group. So if you wanted to kind of address some questions that you maybe have about your own kids, feel free to do so. Do I have to unmute people? I'm not sure here. No, you guys can unmute yourself if you have questions or if you want to enter into the chat.
I don't think I really have a question. I just wanted to thank you for doing this all the time. I really enjoy them. I did see Deidre last week, and that was really helpful. I didn't really have any concerns about my daughter, but I thought it was really nice to just have an assessment and just like a professional opinion on, you know, how she's developing and where I can go next with her development and if she's hitting the milestones. So my daughter's still she's just turning 6 months. So this was a little advanced for her, but it's good for me to know like what to look for in the upcoming months and as she starts walking and running. So again, thank you so much for doing this and taking the time out of your evenings.
Thank you. Thank you for you spending this evening with us.